Okay, yeah, so you're going to get more than just for Dr. Kuntz, where was he? A little bit of behind the scenes of what we could do for skull-based tumors. We're going to talk a little bit more about, I think you'll hear later about how we could use connectomics for guiding surgery, for avoiding cognitive deficits. But we're going to pull the curtain behind about a little bit more of the analysis that we could do with this technology when you get the resting state fMRI. What does that mean, and what can you start to interpret on some of these patients to understand preoperatively and postoperatively how their cognition may be changing, how it is changing, and maybe what the future may hold for using this technology in schwannomas, gliomas, and epilepsy. So. Yeah, okay, great. So, so I'm going to talk, and then we'll have some of my team talk. So when we started looking at cases that were beyond intrinsic tumors, you know, most of my cases these days, I've really transitioned more into skull-based, have been extraaxial tumors. And so, you know, with these tumors, you don't touch the brain, right? A lot of these tumors are outside. So my question are we affecting the connectome when we do these resections? And specifically, a little passion of mine is vestibular schwannomas. And we have these difficult cases of hearing loss and balance issues, and we've been kind of trying to come up with a lot of novel ideas of how to monitor these patients and look at if we could predict how people recover from this, and how they will deal with some of these deficits after surgeries. And so, you know, this is a typical patient here with a 65-year-old with some worsening hearing on the left side who comes to you. And, you know, we wanted to look at first of what these networks look like preoperatively and how they change postoperatively. And we're going to get into a little bit of the methods behind this, but basically when we look at the resting state and how the connections are happening, on the left here, we have kind of the correlation analysis, and on the right we have anomalies. So these diamonds, on the left side of the diamond is a pre-op of every connection within each network, and on the right side is post-op. And then the correlation view is kind of how things are correlated within the tumor. Anomalies is based on the normal 2000 brains that we get from the software system and how we can compare this patient to what it should be, and gives us kind of data, which is really exciting to kind of analyze and to interpret and think about. And so what was interesting, first of all, in this patient is this is an extraaxial tumor in the infratentorial space, and we're seeing a tremendous amount of anomalies and changes in the connectome when there's no real edema, there's no intraaxial tumor, but we know that this patient has some sensory changes because they have hearing loss at baseline. And then postoperatively, we see that kind of gets worse. And what's interestingly is that if we look at where the dominant kind of anomalies are in this patient, we could see that we're seeing language, dorsal intention network, things that correlate with hearing loss in these actual networks that are there even before we touch the patient and then kind of get worse after we touch the patient, almost leading to the fact that there's a signature within the connectome that we could predict this patient has hearing loss if we just don't even see the patient, we just look at their resting state. And then we could actually kind of look at their resting state postoperatively and understand, does this patient get better or get worse, without even getting an audiogram of the patient and seeing how they're doing, which I think is kind of really impressive of the software and its interpretation. And in fact, when we look postoperatively at where the standard deviation of more than threefold is increased in which parcellations are affected, we see again that most of those are areas of language, auditory function, visual, and social interaction, which is where this patient lost hearing postoperatively, and again kind of emphasizes that we can pick up these changes that are happening. They're not me resecting the brain. Like I didn't resect this network or remove this network. It's actually the fact that we remove kind of the sensory nerve, but yet that's affecting the overall cognition and the connectome of the brain, which I thought was kind of really exciting. So we're kind of diving into this in different ways, and to kind of come up with this methodology, Vratko, who's our research head of our research clinical program, and then Richa, who's a research fellow from Rutgers, coming, is going to talk a little bit about how we do this analysis and what we found in some other etiologies. Don't be afraid of Vratko and his English accent, because he's not even from England, but he's really provides a lot of insight into and spent many, many hours thinking about this. So thanks.
Thanks so much, Dr. Ivan, and thanks again for the opportunity. So my name is Vratko, one of the postdoc fellows. I'd like to just take a little bit of a step back. There's people here in this room who've done loads and loads of research on this, and there's people who have no clue what those diamonds are. So I think if we go through it in a methodology way, I think it will encourage a lot of collaboration, especially with the multi-center GCP trial that we're working on. And I'd just like to pose 3 of the key questions that we now think every time we think of a research problem with QuickTerm. There's 3 key questions we like to answer. And we use the DTI and resting state fMRI data predominantly from that right-hand side, which is the functional view. There's also data from the left-hand side, which is the DTI count, but today we'll focus on the functional data. So there's 3 key questions. First of all, is connectivity changing? If it is changing, how is it changing? Is it getting stronger and weaker? And what does it mean for a connection to get stronger and weaker? Clinically or just on the Excel spreadsheet. There's 2 very different things. So how do we define that to make it clinically meaningful when we publish a paper on that topic? And thirdly, are these changes anomalous? Are these significantly different? How do we clinically interpret them instead of just saying it's more or less? What does that mean in the context of skull-based neuro-oncology and lobectomies for epilepsy patients? So the first question is something that Dr. D'Amico mentioned. This has been Connectomics before QuickTerm. This idea of FC analysis has been around way before neurosurgeons dug their teeth into it. And essentially, it's a pretty simple concept that 2 parts of the brain are either firing perfectly in concert and they're bright red, they're +1, or they're perfectly anti-correlated, they're bright blue, they're -1. And it's never really quite that case. It's a spectrum of connectivity. And on the left-hand side, you see an example of a language network from one of our patients. And so you can take this raw data that QuickTerm gives you from the website. You can look at pre and post-op, and the real power is you can do matched analysis. So previously, you might be pooling all the data from the language network, all the data from the sensory motor network, and saying that's the signal. Well, clearly, we have positives and negatives. If we average them out, we'll get something near 0. So that's kind of meaningless. So if you do matched analysis, pre and post-op, you can actually start saying at the resolution of the individual connection, each of those small squares is an individual parcel-to-parcel connection. So that's the first question, and that's something that people in this room have been working on extensively. The second question is, how is it changing? Or what we call directionality analysis. Another way to frame this is, what is the fate of a connection between 2 time points? Because each of those little squares can do several things. It can get more extreme, it can get less extreme, or it can go from positive to negative or vice versa. And so we try to group them into 3 main different groups. Either hypercoupling, the connection gets more extreme, uncoupling, it gets less extreme, or sign switch, so positive connection becomes negative or vice versa. And this way we're trying to, on the left-hand side, you can see 4 example networks that show this. And why do we care about this? Why bother? Well, it's just another way of trying to take quite raw data and give it some sort of clinical meaning in the context of existing literature, so that we're not just firing off clinical questions without the right context. And now the third is the anomaly analysis. So this is already built into QuickTerm, and this is, I think, the most clinically relevant, if you will, because it already gives you a binary output. Compared to those 2,000 patients, healthy patients that Dr. Ivan mentioned, it's either anomalous or it isn't. And it can be either extremely overconnected or extremely underconnected or hyperconnected. And again, we can once again take the pre and post-op scan, do a pre and post-op analysis. And how do we quantify this? Well, we use a scaled measure called percentage of network disruption, because each networks are different in size. Some have 200 connections, some have 2,000. So as a percentage of disruption, you can do that pre and post-operatively and see how is this network doing, if you will, compared to a healthy reference data set. So that's enough of the methodology. We have 3 key questions, and we'll be exploring the results using this analysis in the next few slides. So is it changing? How is it changing? And are they anomalous? Going left to right, we go from the most abstract to what we argue is the least abstract, but still, it's colorful squares on the page. So let's put it into context with some patient data. Now, jumping back into skull base, it's a really nice model to see how networks change irrespective of the lesion location. If you get 10 occipital gliomas and you find that the visual networks are really disrupted, that does not mean that gliomas have a tendency to disrupt visual networks. It just so happens that the 10 patients you chose. So the nice thing about vestibular schwannomas is you can examine these preoperative deficits, and you know that you're not being biased by the location of the tumor. And so what we did in this analysis, we took 4 patients, and you might just think, oh, it's an N of 4, that's a really small number. But actually, when you combine all those parcels, it's about 44,000 individual data points just across these 4 patients. And at the preoperative level, we can compare to what extent are each of these networks disrupted. Again, these lesions are far away from the actual cortical networks physically. And we see that there is a disruption across different networks. And that remains true across other pathologies we looked at, including glioma and meningioma. And so you might think, why do we care? No surgery's happened yet. Why are we looking at this? Well, I think in the context of planning larger scale, multi-center collaborations, knowing what happens at baseline is incredibly important so we can control for it downstream when we carry out the analysis. And now going back into slightly perhaps more surgically relevant question is there a difference, for example, between patients who are newly diagnosed and recurrent high-grade glioma? And why is this relevant? Why do we care? Well, we might want to see whether there are compensatory differences in the hemispheres post-surgery. Because remember, the patients who have a recurrent high-grade glioma, those patients have had a lesion, a resection, chemoradiation, and then the tumor has recurred. So there's really different insults. And if we break the networks into the affected or the unaffected, maybe we could see something even more interesting. So what do we find? Perhaps unsurprisingly, patients who have recurrent high-grade gliomas have more network disruption than newly diagnosed tumors. Perhaps that's not a surprising finding, given the insult that brain has had to undergo to get to the stage of being called a recurrent high-grade glioma. And this is maintained for hyperconnected and hypoconnected anomalies. I think I'll just close with this one slide before Richa takes over. The really interesting slide is, we think, this one, where when you group the networks into either affected or the same side as the lesion, or unaffected, the healthy hemisphere, if you will, the disease-free hemisphere, in the newly diagnosed setting, the networks on the same side of the lesion are more disrupted. But this pattern switches in the recurrent setting, and it's actually the contralateral, healthy, undiseased hemisphere that's more disrupted. And this, again, remains true across hyper and hyperconnected anomalies. And I think the two interesting takeaways, just to close, would be that there's networks that have been untouched by tumor or by resection seem to be taking on more work to compensate for the fact that a lesion has had an impact on that side. And that secondly, this idea that anomaly is always a bad thing might not be the true interpretation. That maybe actually network disruption in the case of a recurrent setting might actually be a beneficial thing. That maybe we should start seeing extreme network disruption as potentially a compensatory signal for a disease state on the other side of the brain. But what about the larger picture? What about neurocognitive deficits, and what about functional outcomes in these patients? And so I'll hand over to Richa to talk about that.
Awesome. So thank you. Now I'm going to be talking about how we can correlate cognitive diseases and cognition to functional connectomics, and how we can actually see the way that functional connectomics can relate to clinical outcomes. So this study was done looking at preoperative patients, and we looked at the default mode network, and we used an MMSE, the mini mental, as a way of deciding whether a patient was had normal cognition or impaired cognition. And we define normal cognition as an MMSE score greater than 24 and impaired cognition as below. And within this 20-patient subset of mixed cranial lesions, we saw that the contralesional side had more anomalies, as Vratko said, in patients that had normal cognition. So we can understand that as that the contralesional side, there is some compensatory measures that are happening to ensure that those patients have stable cognition. And then we also looked at the ipsilesional side in the default mode network, and we selected the default mode network specifically because that network was the most correlated with MMSE and cognition. And we saw that on the ipsilesional hemisphere, there were no significant changes. And then we wanted to see, what about comparing both of the hemispheres together? And then we found that between both of the hemispheres, the more asymmetry in the hemispheres, as in the more lesions on one side compared to the other, the worse your outcome is going to be in these patients, as in the worse it correlates with impaired cognition. And next we wanted to see, are we able to predict how patients do postoperatively based on their preoperative functional connectivity scan. So in this, we also looked at the change in MMSE from the preoperative to the postoperative scan. And we saw that patients that were in the preoperative period having fewer anomalies ended up doing better postoperatively. So in other words, patients that had more anomalies in the preoperative period ended up having a worse MMSE score postoperatively. And then we stepped back and looked at the whole brain and the total amount of anomalies in the whole brain, and saw that that was a consistent pattern in the whole brain and also the contralesional hemisphere. So we said that more preoperative disruption predicts a worsening of postoperative cognition. And then now switching gears, we were talking a lot about brain tumors, and we know that Connectomics has mainly been used for brain tumors, especially the software. We tried to see how we can use the software for epilepsy surgery and Connectomics. So we looked at a 5-patient cohort that underwent lobectomy, and our first analysis looked at the directionality analysis, which Vratko explained very eloquently about what the fate of each connection is postoperatively. And these fates fall between 3 different types of directions. One that is defined as uncoupling, known as the value becoming closer to 0 and a signal becoming weaker. Hypercoupling is known as the FC value becoming more extreme and either towards -1 or 1, and switch is when a negative value becomes positive or vice versa. And we saw that across the board in all of these patients, uncoupling was the most common directionality in the whole brain and each hemisphere specifically. And then we wanted to see, is this pattern consistent in each individual cortical network? And we saw in the whole brain, yes. In all of these networks, you can see that uncoupling, as in the signal becoming weaker, and a dampening of the signal in the whole brain is consistent across each network. Then we looked at each hemisphere individually and saw that the networks that contributed to this significance were different. However, combined, we can see that this is a similar pattern across the whole brain. And finally, we went back to our anomaly analysis in our epilepsy patients and saw that the total amount of anomalies, while they didn't necessarily change from the preoperative to the postoperative period, we did see that the contribution of each type of anomaly did change. So the blue represents hypoconnected anomalies, which are those abnormally disconnected connections, and the red defines the hyperconnected anomalies, which are defined as hyperactive anomalies. And we saw that the total amount of hypoconnected anomalies did increase and the hyperconnected anomalies decreased. And in the setting of these patients that underwent lobectomy, at their post-operative scan, they were all seizure-free. So this directly correlates with their clinical picture of seizure freedom and this dampening of the signal that is seen throughout the brain. And just some key takeaways from this study: resective surgery results in this quieting of the brain and network quiescence that we see, which aligns with seizure freedom in these patients. And that's seen through both types of analysis, our directionality analysis and our anomaly analysis. And those were our key findings for our epilepsy study. And then I hope you were able to get a little insight about some of the research that we're doing at University of Miami and how we use Connectomics across the board, from skull-based to neuro-oncology to epilepsy. And I want to thank Dr. Ivan and the rest of our amazing team for their great work.